So this is the project we started a couple of years ago and has had a boost in the last year. It's about the effect of prostate cancer metastasis in bone and how to try to prevent the pain in prostate cancer patients. That's the main goal of this project. And as a disclosure, I have to say that we're totally biased in this presentation because we are absolutely committed with the foundation, with the Prostate Cancer Foundation of BC. Probably very little of this project would have been possible without the support of the foundation. We obtained the award last year, and that allowed us to have some support. First, second, we obtained a later scholarship because of this grant. I get the Michael Smith Foundation. That also helped us releasing money, hiring more people, and the project has I would say an exponential speed since that moment. So first of all, I need to acknowledge the Prostate Cancer Foundation of BC because of that. And most of the work you will see from now, you will not be able to see it without your support. So thank you to start. And the first thing is, Len asked me, please explain me, you're from Chile. And I said, yeah, Chile. I need to explain where Chile is to a lot of people because it's not a big country. It's kind of in the bottom of America. We are the southern country of all. When they say I'm going south, no, you're not going south. I live south, you are going southern, but the south is there where I used to live. Really well known because of the scenery, the wonderful scenery, this wonder of nature between the Andes and the Pacific Ocean. It's just the west coast of the Andes, right? So the highest mountains, the biggest chain of mountains in the world, one of the highest mountains facing the biggest ocean. And that's the wonder of. Then you have the altiplane, the driest desert in the world, where most of the astronomical observation happens on Earth is there. And 5,000 kilometers of beaches, wine country, good wine there, Patagonia and Easter Island. That's the main reason why Chile is known, and that's where I live. And for those of you that are probably my age or older, you probably also remember Chile because we used to call this guy our president.
Yeah.
Probably one of the biggest criminal of modern history, and we were used to it, and that was. Now you think back, and it was crazy that I grew up in that place with that guy being the ruler of our destinies. And fortunately, when I was like 12 years old, democracy came and a new life started for all the Chileans. The happiness of living in some freedom and democracy was something that you can breathe there. You could breathe there during the 2000s. And also the economic growth came to Chile with this wonderful area of Santiago that we call it Sanhattan, because it looks like Manhattan, but it's in Santiago. It's the tallest building of the Americas, beautiful parks, everything nice. But in this wonderful image that we sell to the world, we have 1 million people living under, or more than 1 million, probably 2 million people living in these conditions, basically in camps under the highways. This camp is from this year, it's a new one, with homemade houses made by wood or cardboard or whatever, really extreme poverty. As that's the main contrast of Latin America, and that's the main reason, the main struggle that the Latin American has. And in that context, I decided to study dentistry and get a super social focus to it and try to help the people there. And that's me in my early days as a dentist, trying to working in these camps with extreme poverty. And I understood during my dental degree, during my dental practice, that the main problem we have as a practitioner, as a dentist, is that whatever material we use to fix teeth, taking cavity as the main disease, they don't work well over time. They're always leaking. They're always they don't attach properly to the teeth, and that's the main challenge in dentistry. So I decided to study that. And Len asked me why you came to Canada, because when I was studying that in Chile, I met a professor from materials engineering in UBC, Dr. Wang, that he was studying also mechanics of teeth. And I wanted to study how the chemistry and the mechanics response of teeth, the structure of teeth, make it easier or harder to fix it. And that's the picture of my presentation in China. The only picture I have from that conference with my supervisor, Dr. Fernandez, 15 years ago and 15 pounds ago, I will say. And that was my meeting with Dr. Wang. So years later, I wrote him and I came to Canada and we started working together. And that's why I'm in Vancouver, because of that meeting with this gentleman here. And what we did as in dentistry was what I just told you, analyzing the structure, the histology, how the tissue is in the structure, and how this structure of the tissue allows the mechanical or drives the mechanical response, how the tissue bends, it's hard or soft, and that always aiming to understand why this mechanical behavior of teeth will allow an easier restoration and how the materials of restoration will match the mechanical behavior of the natural teeth. If both behave the same, the restoration will go well. If they don't, the restoration will fail. And that was my goal. So in that way, I get a high expertise in understanding a structure and mechanics of teeth and bone, because dentin and bone are quite similar materials. So when I came, then I started my PhD with Dr. Wang, and Dr. Wang gave me a nice surprise and told me, Felipe, you know, nobody cares about teeth in this country. So the best way to work with you will be working hip implants. He introduced me to the head of the orthopedics at the time, Dr. Masri, who was my co-supervisor. And they told me, you know, hip implants fail a lot and they're having a big disaster right now. And that was true. In 2010 was the main, 2010, 2013 was the peak of this problem. So we start working in, again, materials, metal implants in bone and how they fail. That was I realized it was a big issue that. But I wanted to work with more biology. I said to my supervisor, you're a materials engineer. Dr. Masri is a surgeon. I want to work with cells. And that's why I was introduced to somebody that all of you know, which is Michael Cox. He has a cell biology lab and we start working and seeing how the tissue responds to the implants. And that's how I did my PhD with Michael Cox. By the end of my PhD, Mike Cox introduced me to Larry. I guess most of you know Larry Goldenberg, and amazing guy too, a fantastic person. And he showed me his dark side. His dark side, he asked me, Felipe, why don't you work in prostate cancer? That was his statement. And my answer was, Larry, I'm a dentist, of course. I'm a dentist with experience in structural biology, with experience in bone and teeth and mechanics, and basically I know nothing about prostate cancer. And besides, I want to work in cavities, in dental cavities, which is the most prevalent pathology of the world. I didn't know at that time that Larry always wins every conversation.
Yes.
He always gets what he wants and always have the right argument. So when I told him dental caries is the most prevalent disease of the world, 90% of the population have it, he told me, well, Felipe, prostate cancer is the most common prostate cancer in men by far. I told him, yeah, but it has a low lethality rate. No, it's not a problem anymore. He told me, low lethality, 3.45% of men die of prostate cancer. I said, wow, that's important, but Larry, you're cheating here because this is developed countries. Developed countries, 3.45% of men die of prostate cancer, not the developing world, not the third world countries. And he told me, no, third world countries or developing countries with good life, with good healthcare, they have a health rate too. So Chile is almost 3%, Uruguay almost 5% of men die of prostate cancer. And that's how Larry won, basically. And I started working in prostate cancer.
Oh, I see.
So I guess I get to the answer that Len was asking me before. But so when I was starting to work in prostate cancer, I realized that about 90% of advanced prostate cancer metastasis goes to bone. The main site for prostate cancer metastasis is in bone. And of course, is where the problems will start after you have a total radical prostatectomy. Because when you have a radical prostatectomy, you don't have no prostate anymore. Where are the cancer cells? Where is the cancer now? The cancer is in bone. I said, well, it seems that I have an opportunity. I know about bone. That's my strength. And the more important part is I learned that they generate severe pain, fracture, and spinal cord compression. So it sounds to be a real problem for prostate cancer. I didn't know at the time, to be honest. And importantly, the lesions, the type of injury that the prostate cancer make in the bone is not much of a bone destruction, but it makes more bone. So the bone became like thicker, bigger. It makes more bone, synthesize more bone. And I found that was something that we need to study. And I have the combination of knowledge to start studying that. So that's how we decide to do that. To see how important it is, I start checking literature. 42% of patients with metastatic disease have skeletal related events, basically pain in bones. 50% of the patients with metastatic disease in 5 years. And I said, well, this is not the top journal, Nature Review Clinical Oncology. The most effective strategy to reduce skeletal related events will be to prevent bone metastasis. Seems to be the main problem of patients with advanced prostate cancer, so we jump in. So that's how we decide to study this. And to proceed and to make this talk more friendly, let me talk about bone structure for a second. Forces we divided basically in tension and compression. Tension are the forces that tends to separate things from each other, pulling away one thing from each other. And vertebrates, we managed to survive that by having one specific molecule, one protein, which is collagen. Collagen fibers are these fibers, as the word says there, that you see in the image there, that like real steel wires keep our body all together. And in a tendon, they align perfectly aligned to make the force to resist the tensile forces axially. And in a skin, for instance, our collagen fibers allow to resist tension in every direction. When you pull the skin in any direction, the skin will remain in one piece. So collagen fibers are the main structure for vertebrates to stay together in one piece, basically, under tensile forces, and keep us together as one singular structure. And that's bone has collagen. But some of you will tell me, how do we humans deal with compression? Collagen fibers, as every fiber, is done to resist tension, like any chain or yarn or whatever thing is good in tension, but not in compression. They bend in compression. How do we deal with compressive forces? Is by putting minerals on the collagen. We put minerals, and the minerals, the crystals, give us our compressive resistance. And how humans do it, how nature make mammals grow, was having mineralized collagen fibers. So we have collagen fibers that are excellent to resist tension, and we put mineral on top, and they're also excellent to resist compression. As a perfect design in nature, that's how our bones and teeth are made, out of mineralized collagen fibers. So these mineralized collagen fibers organize in plywoods and make big structures like bone. This is critical because that's the way bone keep us straight in our position, resisting all the forces compression, tension, bending, and all the kind of forces that our body resists. And I thought this is key. See how this is affected. So from here, I have a few questions for the project. If prostate cancer generates pain, fracture, and weakness when they metastasize to bone, then what are the changes that generated by prostate cancer and bone? That's the first question we have. The second is how those changes generate pain and weakness. And the third one is how does it happen? Which mechanisms of the prostate cancer make changes in bone to generate pain and weakness? So that's what we try to solve. Thinking always that the main goal is to help patients with prostate cancer metastasis to have a better quality of life. The main problem we have is we have no samples, and that's back to the problem. The first thing I told is, Mike, how do we get samples? I cannot do anything if I don't have samples to study. And Mike said, I have a couple of friends in the University of Washington, Dr. Con Morrissey, Dr. Eva Corey. They manage an autopsy program. It's called Rapid Autopsy Program. Patients with prostate cancer sign up a consent in advance. And after they decease, after the death, the first thing they do is they go to anatomical pathology and they take samples, biopsies of different tissues, and store them for research. So we give them a call and we talked to Dr. Morris a few times. I told him, this is my idea. Do you have pieces of bone? And he told me, yeah, I have pieces of bone stored and we haven't used it because we don't know how to deal with them. We asked him, can you send us a few as a proof of concept? And he said, yeah, I'll send you. And he said 14 specimens of vertebral samples. We have 14 samples of vertebrae of patients who die of prostate cancer. There are pieces like this, 1 centimeter diameter, a few centimeters in length, and we said, okay, let's analyze them. Due to my previous background, I worked really closely with Dr. Dan-Mei Liu. She manages the Center for Hip Health and Mobility, and she has a CT scan, a super high resolution scanners to scan samples. And this is what she saw. So when she saw this image, she told me, Felipe, these samples are special. Come and see them. We met and we said, well, this is how the spongy bone of a vertebrae will look when it's kind of normal. We don't have normal samples here yet, and that's why I told you the important part of getting the normal cadavers was to obtain the normal version of this. But this is more or less normal. Is the spongy bone, vertebrae are mostly a spongy bone formed by this thin trabeculae with a lot of space in between. That's more or less how a normal bone should look like. But our prostate cancer metastasis samples look like this, or like this, with absolutely a higher mineral content, much more bone than usual, and the bone grows in between the spaces. There's no spaces here. It's just bone growing in between, and some bone growing in the surface. And even some samples have no remaining trabeculae at all. It's only a mushy structure with no structure, totally irregular or disorganized bone generated by the prostate cancer. We want to go on deeper analysis, and this is how a big image will look like. This is more or less a kind of a normal side of the bone, and this is how we see the part that has the prostate cancer inside, with a irregular structure, with absence of trabeculae. And then the question is this generating the pain and weakness? Is this a spongy bone, this irregular bone give enough mechanical resistance or enough mechanical properties to deal with the tension, the compression of the bone or not? And structurally, what happened with the mineral composition and the collagen alignment I talked to you before? Is it normal? Does it have normal mineral content or not. So during my PhD, I worked hard, really closely to this gentleman, a close friend of mine, Chung Wang. And he works with extreme high resolution electron scanning microscopy. And this is a sample of those ones, a bone of a patient with prostate cancer. And we can see the part that looks like a normal bone here in between. It looks brighter in this case. And the abnormal bone or the cancer bone is here. Absolutely irregular, a different color, and more holes. We see more lacunae here, more holes, more voids there that are usually generated by the presence of a cell inside. We decide to count them, and we know now that this bone, the cancer or the abnormal bone, the irregular bone, has much more spaces than the normal bone. And we recently, as I told you, we got a lot of assistance by a good group of young students, and Jacob is one of them. And he works with confocal microscopy. And I told him, can you do a confocal microscopy to see the three-dimensional shape of these holes here? And in the normal side, he showed me what the textbook of bone will show you. Cells that are there, the red thing is, these red things here are the cells, or the space where the cells live. And the cells in bones, they are in the mineral matrix, they have these branches, these canaliculi where they contact to each other and they touch directly each other. And we can see them here, full of canaliculi. This cell is full of canaliculi and branches, trying to touch other cells, which looks like totally as a normal bone. And when we did the same analysis, the same observation in the cancer bone, the cells look totally different. The space and the composition look totally different. The cells don't have canaliculi. The cells look more bigger, rounded. It's a totally different shape. So basically, here we have a moment in we know certainly that the cancer or the disorganized bone or the metastatic bone has a totally different structure than the normal bone at this point. Also, through my past through engineering, I was lucky to meet Qing Su, an amazing engineer in physics that works now in computer engineering. And he developed a technology to determine whether collagen fibers are aligned or not, are in right orientation or not. So based on this backscatter electron imaging, which is similar to this image, we have normal bone, what we know normal bone here, in labeled as yellow, in the yellow arrows, and all the, we'll say, new bone or cancer generated bone is all this trabeculae, all this white thing you see here. Black here is just an empty space, where is white is mineral, so it's bone, which in this case here we have all this new bone. And I asked him, can you, with the technology you develop, can you analyze these samples? And he said, of course, let's do it. And what he found is, he found that the collagen fibers that I showed you at the beginning that are critical to have tensile stress and probably compressive and resist compression forces have a proper alignment or a good alignment in what we know as and what we see as normal trabecular bone. These are parallel images. So blue means more aligned and red means totally disorganized bone. So in this area here, this arrow here that you see is the same area in this other side here. I think my pointer should be better. Can I do it? No. No, should I? No, I cannot. Yeah, how can I fix it? Let me see. No, I don't know how to do it. Anyway, well, here you see in the, so what we show here, what he observed is that the collagen fibers are perfectly aligned as they should be in the normal trabecular bone. But this new material, this new bone that's generated by the prostate cancer, we presume is generated by the prostate cancer, the collagen is not aligned and the structure is totally missed. So summarizing in our material analysis, we know prostate cancer metastasis generates more mineralized tissue, bone tissue. That's what we know by the scanning. We know that this bone is more porous with abnormal shape of cells. That's something that we already know. We also analyze the calcium content, and we know the calcium content of the prostate cancer bone is irregular. And the non-aligned collagen suggests that it has a lower mechanical properties. What are we doing right now? Naomi, who's in this meeting, you can see her there watching the presentation. She's doing the mechanical test. She's biomedical engineering. She loves mechanical testing, and she's trying to do a mechanical test to see if the cancer bone is weaker than the normal bone. By nanoindentation, she's having preliminary data showing that there are differences in elastic modulus and hardness. To be confirmed, this is just preliminary data, but we hope in the next month or two have conclusive data here. And what's coming in this part of the project? We have collaboration with Professor David Cooper on the University of Saskatoon, and also in the Canadian light source, where the synchrotron facility is. And we were lucky to be there before and take this kind of imaging, taking scanning images with higher resolution than what we have now, much higher resolution. This is a synchrotron facility, it's a $300 million facility. So we expect to have a much higher resolution there. And also, a close friend of mine, Tony Tang, we also make the PhD together in the same lab. She works in McMaster now with a machine that's called Focus Ion Beam that can give us high resolution. Of this is her paper, actually. These are her pictures that she took when she was in Germany, Max Planck. Now she was hired in McMaster to do exactly the same. This is how she can take images of collagen fibers and mineral at that level of resolution. We're talking about nanometric, basically atomic resolution, to see if we can identify where the fibers are and how the mineral organize, and to see if the prostate cancer vertebrae or bone this happened or not. We have similar or different mineral content. And so that's about the material part of view, and that's the part when you say how a dentist with materials engineering come to work in bone. Yeah, that's the kind of contribution we can see. We can now analyze the bone as a material and do materials analysis and see how it's weak, how it's organized, how the structure it is, and if this structure is the one that generates fracture and pain or not, and how it happened, and if we can prevent it or not. Now we go a bit more biology. We said what happened with histology and proteins, how the structure of this tissue align with protein structure or with the chemical composition, the biochemical composition. And here a few months ago, Beta joined the group. Beta, who's there is also in the meeting. Oops, what did I do? That's it. And she started doing histology, and she has done a lot of work here, cutting sections and trying to analyze them, taking pictures, and trying to identify the difference. And we have seen constantly that there are absolutely different structure between this lamellar bone, this normal bone. This is normal trabecular bone that you see bright here in this picture, or red there, and the non-aligned bone, the non-normal bone that's doesn't shine here or looks blue in the other picture. And then when we analyze with different stains, they stain totally different. So with this method, we try to understand if the biochemical composition of the bone is different or not, and which are those differences. So we use antibodies and different staining techniques. So to don't make it too long, all the histological analysis we have done on this, basically getting this kind of stain showing how the prostate cancer bone actually stains different than the normal trabecular bone. We know that the disorganized bone has clear histological differences with the trabecular bone. In both bones are composed by collagen 1, which is the most fibrillar, the typical collagen of bone. Disorganized bone has higher contact of collagen type 3 and proteoglycans. Why is important? Because these two molecules are present in reparation. When you have a bone fracture and it repairs, the first thing that happens, it has a lot of collagen 3 and proteoglycans forming a callus. So probably here, the signaling is going to repair or to the sign of fracture or failure more than generating a different tissue, because look like a normal, the structure is similar to a bone that's healing when it gets fractured. And no cartilage is present because no one of the molecules of cartilage is present there. That was one of the questions. Could it be cartilage that's calcifying instead of, could the prostate cancer bone being cartilage or a cartilage structure? And by this immunohistochemistry studies, we determined that's not at all. We have no collagen 2 and different other molecules that are not present, aggrecan, etc. And what are we doing right now? Beta will do analysis of distribution of the structural and functional proteins in prostate cancer metastasis, and she will be doing that for the next 2 months to have a total picture of how the biochemistry of the bone is different and what are the elements that make it so different. We had a few days ago a good news. The Professor Colm Morrissey from the University of Washington talked to Michael Cox and told him, Mike, I think your work has been really good. We want you now to send you more samples. I told you before he sent 14 samples out of the hundreds they have. He said, now we're all in, we're sending you everything.
Wow.
Which is fantastic because now we have all the samples we would possibly have. Why is critical? Because cadaveric program, I mean, autopsy programs like the University of Washington, it's only one, it's unique in the world. I think Finland had a program for a few years, and that's it. Nobody else have these samples in the world. And this team of the University of Washington now want to share them with us, which is a great news for us and also a good compliment saying we're good, go all in. The big problem is it takes so long to process 14 samples. Now we have to process 100, so it's a big problem for us. We will do it. It will take a lot of work, and we will be working hard to do that. But that's the great news we have. Now, any of you will tell me, well, you have been working only with cadaveric samples, but the patient already died. The samples have been stored for a long time, so you cannot do much cell analysis. And that was a big problem. And again, come to the problem of the samples. When I start this project, I said I ran into anatomical pathology VGH and asked for these samples. Do you have, and they directly went to all pathologists there. Do you have metastasis, bone metastasis of prostate cancer? And they told me, no, we don't have them. There's none, we don't have it. I went to talk to orthopedics department. Do you have patients with fractures because of prostate cancer? And they said, yes, we have about 16 a year, 16 vertebral fractures. And in the hips and long femur, they told me about 10. So we're talking about 25 patients in Vancouver came to surgery because of fracture due to prostate cancer. It's not a big number, but we have to think that not everybody gets to the fracture point. Most of the people have pain a lot of time, long time before having the most catastrophic failure. So we're not talking about a small core. We have a bunch of patients, but the only tissue we can get is from fractures. So I talked to the surgeons and I told them, but you don't do biopsies, because I went to pathology and they say they have no samples. And the surgeon said, we don't need a biopsy. The patient is already prostate cancer positive. We know it's prostate cancer. Why would we want to do a biopsy? And I asked the surgeon, what do you do with the tissue then? Well, we discard it. It's incinerated, as every sample that comes from a human body. And then I met these two amazing guys. So I went talked directly to them, to Rafael Charles Morin, a spine surgeon, the Department of Orthopedic, focused on oncology, and Pierre Guy, two fantastic surgeons and really involved in research, both from the orthopedic department. I met them before during my PhD, so I knew them personally, and I talked to them and said, guys, can you give me a call when a patient comes and we can collect samples? And they have done every time. Now we have 8 samples of spine and 6 and 1 hip fracture so far, which is fantastic, meaning that my phone rings anytime and Rafael said, Felipe, there's a patient with a fracture, a spine fracture, going to the OR right now, show up. So I go in the moment. I have to say that that moment is really painful, it's critical. The patients come with a spinal cord fracture, really reduced mobility, pain, absolutely in pain, and it's an emergency surgery. Same with the hip. And we're lucky that the patients agree to consent and help us obtaining the tissue from them. As you can see, again, the patient part is critical to know what happened. So going to the anatomy of a vertebrae to explain why it's hard, usually the metastasis happen, the fracture happened here in the body of the vertebrae. This is a vertebrae, normal vertebrae. The spinal cord goes in the middle of this hole, all the way from the brain to the back, all the way to the sacrum, right? So it goes all the way down in the middle, in this part. In a side view, it goes like this. And the part that failed, the mechanical support of the spine is the body of the vertebrae, this part, the big part of the front, the body of the vertebrae. That body of the vertebrae is the one that fails when this fracture happened.
Really?
But it will never be removed. What we can obtain of those patients as a sample is this part. Why? Because when the compression happened, the surgeon needs to open the back, needs to take this out in order to see the spinal cord and release it to give the patient, stop the pain and give them mobility again. And the vertebral body is kept there because it's the base of the structure. You cannot take it out. If you take it out, the patient, yeah, it's absolutely critical. Also, nobody wants to do it. The aorta artery passes just right there. So basically, taking it out is more risky than leaving the patient with a fracture. So we will never get the vertebral body. But we can have this piece, is the vertebral part that they take out in order to see and be able to fix the vertebra. And this is the kind of surgery it happened. This is a real case. The spinal cord is compressed by this tumor. And this is a vertebrae absolutely gone by prostate cancer, fracture. And what they do, they screw the top and the bottom vertebrae and release the pressure. So first I straight it up with some mechanical techniques and put these screws on, and then apply a lot of irradiation here, so the cancer is gone, and some chemical adjuvants to regenerate the bone. So that's the way it works. And that's the kind of samples we have, and that's the kind of pain the patients are. So far, when the first surgery happened, we have a piece of this tissue. And what I did, I called Naomi again. I said, well, let's scan the sample to see if we have any hint that there's cancer bone. So we fix it first in formalin. We run to the scanner with Naomi, and Naomi take these images and said, yeah, there's your disorganized bone seems to be there, this non-regular structure that's in the middle. And then we can process and do histology and find the cells and see where they're. And that's how we start working with this a couple of years ago. Well, 1 year, because to be honest, also the pandemic stopped the process. We were not able to go to the OR for 2 years. So basically we start during January to collect samples. And this is one case. These are 2 of our cases: a spinal cord fracture, a spinal cord compression here and here, which have the traumatic consequences. Both patients did well after the surgery. And we could analyze the cells on the tissue, and we can see where the cancer cells are. So we found the first finding was the cancer cells do 2 things. Well, basically 3, but 2 mainly. One group of cells tries to build a new prostate there. They still believe they're a prostate, and they make kind of a prostate structure here. And another group of cells forget that they're prostate cancer and they go and attach to the bone right here, as you see right here. The prostate cancer cell, here we stain them with PSMA antibody, which give the brown color. They are stained in brown, the prostate cancer cells. And I will show you in the following series of images why we think what we think. So this is again another low mag regular histology, the antibody against PSMA in red, and you can see these cells that I say they are trying to make a new prostate. Why do I say that? This is a high magnification of our vertebral metastasis, and this is how the cell look like. They're forming these structures, these acini, these secretory units. And this is how a prostate look like with the same stain, but in brown, it's just a different color. So the prostate cancer, the prostate in general as a gland, the cells organize making this acini or these secretory units that leave a space in the middle where the prostate fluid goes. But the cells organize in the periphery, in the edge. The nuclei of the cell here are in blue, and the top of the surface where the cells secrete prostate fluid is in the top, and that's where PSMA locates. And here we see exactly the same distribution, this kind of tubes with a space in between, with PSMA in the edge, all in the surface, and the nuclei organized around it. So these cells deeply believe that they are still a prostate and they're trying to resemble a prostate, and they are inside of the bone. And the other group of cells goes and attach to the bone. This here is a bone surface. This is a piece of bone. And in red, we stain for androgen receptor, which is a marker for prostate cancer, and pancytokeratin, which is a marker of epithelial cell, prostate 2. So the brown and red cells are prostate cancer cells. And the ones who don't stain like that one, or the one I point here with the white arrow, are bone cells that are in the surface of the bone. So prostate cancer cells get in direct contact with the bone cells. Doing what? We don't know yet, but they are talking directly. So yeah, this is more or less what we have seen. So this direct contact is what it calls our attention. So I asked Beta, can you do the same but with fluorescence and makes more markers? The advantage of fluorescence, we can do more things because we can have more colors. In immunohistochemistry, this stain, we have basically a red and a brown that actually they look really similar, but with fluorescence, we can use totally different colors and have better imaging of the cells and identify more cells. And she gets the same result. A bone cell right beside a prostate cancer cell, just touching each other. So prostate cancer cells, a group of prostate cancer cells that go to the bone, get in direct contact with the bone cells. Probably, we think, telling the bone cells to make more bone. And that's how this new bone starts making it fast and grow so quickly. Also, Beta found some immune cells, cells of the immune system, trying to fight this cancer they are in. So what we know about this cell analysis, we know prostate cancer cells are present in the cell sites of abnormal bone formation. They are mostly androgen receptor positive and double negative. There are no neuroendocrine cancer cells there, for the ones of you that are more deep in knowledge of the prostate cancer. Some prostate cancer cells resemble prostate histology. Other prostate cancer cells take intimate contact with bone cells. The nature of this contact, we don't know it yet, and that's what's coming. What is coming? You see there in the image, Atsuhiko just arrived a couple of days ago from Japan. He's a surgical fellow, and he will try to do this. This technique is called multiplex immunofluorescence, in which we can stain up to 20 or 40 markers to identify every type of cell in the same slide, aiming to identify all the cells that are there. And working on that will take probably a couple of years. To be honest, it's a technique that's highly complex, needs a lot of work and a lot of standardization of antibodies and selecting the markers. So probably he'll be here about that time doing this. Hopefully, to identify different type of prostate cancer cells, how they locate, how they interact with each other, where the nerves are, something that I'm really interested because this generate pain. So we need to know if the nerves are in contact, if they approach the nerves or not, and whatever Atsuhiko decides to work with. And also we hope to do digital spatial profiling that will give us more of a functional state with Dr. Torsten Nielsen, which is really he's really a brain walking on the earth. It's one of those genius people that work somewhere, one of the brightest persons in the center, and he's a professor of pathology, director of the program of pathology in UBC. And he is really interested in this project because he came to a couple of, even he came into a talk here. He said, I haven't get any sample of this. How do you get them? How does it work? Can we do spatial profiling? The spatial profiling will allow us to know what the cells are doing, more of what the prostate cancer cells are doing, how are they communicating with the other ones? And that's what we're aiming to do in the next year or two. Hopefully Atsuhiko will help us there too. So when we start, we said we have a few questions. What are the changes generated by prostate cancer in bone? And we have some answers there. We know it's more bone, it's disorganized, it doesn't have a proper structure, seems to have different mechanical properties. How this generate pain and weakness? It seems that we have, well, we don't have a clear answer, but if we have different mechanical properties, probably there are microfractures or compressive forces that generate some of the issues. And finally, which are the mechanisms? Here are we far yet, but we aim to follow working in the coming years. At the end, I want to acknowledge, first of all, in BC, I learned that in the aquarium and in the museum everywhere, the bigger the square you have or the logo is, the more money you put. If I have to acknowledge in the same way by importance, the patients and their families will be by far the biggest, and probably will not be room in the screen to see anybody else, because they are the key part of this project. Without patients and families and support, we can do nothing. Also nurses and people in the hospital that are really helpful every time we try to obtain the samples and explain what we're doing. The anatomy department of UBC, really friendly and supportive. The foundation and institutions from Chile and Canada that helps us taking this project. So thank you so much, and I hope it was clear and I answered the questions you have.
It just looks